I'm going to record to the cloud. So it is my great pleasure to introduce my wonderful colleague, Dr. Hermione Lyall, Pediatric Infectious Disease Consultant at Imperial College Healthcare Trust. And Hermione is a national and international expert on bloodborne viruses in children, and also increasingly has a national and international reputation for her work on congenital infection, especially syphilis and CMV. So Hermione, thank you very much for doing this talk.
Okay, Gareth, thanks for a very lovely introduction, and apologies for the fact that we don't seem to be able to put this into presentation mode. But I want to Gareth just asked me to sort of talk to you today about people to start talking about scorch rather than torch. And this is really all about thinking much more broadly about what a congenital infection might be than people used to think in the past. And the throwaway phrase was, oh, do a torch screen. And the torch screen was basically a serological screen and interpreted differently by different people, but some would do Toxoplasma, maybe other rubella, CMV, and HSV. But I think actually the possibilities of what you might have for a congenital infection are much, much wider than that. And this is how we came up with and what was really often being missed in the UK was congenital syphilis. So that's why the S is at the beginning. The commonest of all really is CMV. Other includes a whole batch of different things, which depends a bit on where you are in the world. R for rubella, T for toxo. We've got C here for chickenpox, which is obviously VZV. And then here we've got all the H's, which includes HSV and all the bloodborne infections. And really, when we're a pediatrician or a neonatal team, or indeed an obstetrician thinking about a congenital infection, we need to think broadly about what it might be. And we put together in the archives an article last year on just thinking about the toolkit that we could use to take a kind of diagnostic approach to a suspected congenital infection. Much more than just saying do these tests, we really want people to think about what do they see in front of them? What is the clinical syndrome? What is the clinical scenario? And depending on, is there sepsis? Is there abnormality in the brain? Is it a blueberry muffin baby? Are there blisters on the skin? Is the eye involved? Is the baby deaf? Does the baby have hepatitis? Are there cardiac anomalies, limb anomalies? Is the baby growth restricted? Are there abnormal antenatal scans? So thinking more about what systems are involved, and then putting that together to think, well, if it's eye disease, we must think about CMV, Zika, etc., etc. And then we decide what sort of tests we're going to do. So instead of doing it with a torch screen, which is somehow or other backwards, here we're starting with a clinical scenario, engaging our brains and trying to think through what infection might be causing the problems you see in this fetus or this baby. Now, if you look at what infections we actually screen for, and this is a comparison between Greece and the UK, but you could look at any resource-rich country around the world. And at the moment in the UK in pregnancy, we only screen for HIV, syphilis, and hepatitis V. Whereas in other countries, they do far broader infection screening for all the hepatitis viruses, rubella, CMV, Toxoplasmosis, and syphilis. So, and indeed, in Greece, they repeat the screening in the end of the second or third trimester in case there's evidence of acquisition of infection. And different countries have different prioritization, and indeed, for that matter, screening categories. And so, you know, in the UK, it's extremely hard to get a new screening test onto the books, because it has to fulfill some very, very stringent requirements. But having done this talk with you, I hope you might be thinking later about some other infections we might want to screen for as well. So the timing of transmission is really important. And of course, the type of bacteria or protozoa or virus that we're looking at in terms of transmission also makes a difference. Some of these infections are very much perinatal, some of them are intrauterine. So here we have a little baby who you'd call a blueberry muffin baby, because you can see these kind of slightly bluish bruising where there's hematopoiesis actually happening in the skin, as well as some petechiae, because this baby's thrombocytopenic. So there's multi-system involvement here. This baby may have microcephaly, pneumonitis, may have bony involvement, has the rash, hepatosplenomegaly, and so on. But the question is, which infection is causing this sick newborn to be a blueberry muffin baby? And we need to do our very best to make that diagnosis as soon as we can, so that we can make sure we start the right treatment. And I'll just highlight here this very, very important organ that is always just getting thrown in the bin. But if a baby comes out who looks sick, then what you need to do is make sure that you get the placenta, because the placenta can be an extremely good way of diagnosing syphilis or toxoplasma or other infections. So a piece of placenta to microbiology and to histo is really useful. So sorry about this, because we can't seem to find the way to get into presentation mode. But when we're thinking about making the diagnosis, we have to be very clear about the sampling and the history that we need to take. And it is not just a question of taking that blood test from the mother. We need to make sure that we actually get really good samples for culture and PCR, whichever is appropriate. We get paired serology from the mother and the baby. And just to highlight that looking at IgM, so new antibody production in a newborn fetus or a fetus, is not necessarily very helpful, because newborns are not good at making IgM. So the IgM may not be positive until several months later. So that is why we need to do the PCRs and get the actual tissue. Okay. So let's look at some cases. Here is a 2-week-old infant who came into our ward with a lactic acidosis. This baby been unwell for 5 days, poor feeding, vomiting, noisy breathing. Mention was made that this baby had had a blocked nose really since it was born, had some blistering lesions as well. The baby was the product of a normal pregnancy, and the booking serology from the mum was nothing of concern. The baby was a reasonable weight. Healthy parents, no consanguinity, no known infection contacts, and no recent travel. And here you can see these lesions. There was a blister on the baby's eyebrow, and also a blistering lesion here on the lip. Baby had some quite abnormal investigations. You could see it was acidotic with a raised lactate, had a high CRP, a low sodium, had abnormal liver function, it was hypoalbuminemic, it had a very low hemoglobin and a very high weight count, and it was thrombocytopenic. And it had lots of nucleated red cells. The clotting was normal. The baby had a normal lumbar puncture. And all the cultures were clear. and there was some patchy consolidation on the chest X-ray. But we were very worried about the sick baby. So we're wondering, was it bacterial sepsis? Was it listeriosis? Could it be HSV, TB, leukemia, mitochondrial cytopathy, or something else going on? And this is what happened to the baby's skin over the next few days, really very thick desquamation. And here you can see on the hand, and you can also see that there was a blistering lesion on the hand as well. So actually, the mother hadn't traveled anywhere, but the father had, and he had been to on business in Russia. And as a consequence of that, although mother's serology was negative at booking, she had acquired syphilis during pregnancy. And unfortunately, she had also acquired hepatitis C. And dark ground microscopy, so just taking an imprint of those blisters, was enough to show us the spirochetes here. The baby was IgM positive, and the paired serology confirmed that both mother and infant had syphilis, and this was a case of congenital syphilis. Now, if you ever want to get information about infections in Europe, you should go to the ECDC website. And there you can see here, we've got syphilis as it is in Europe at the moment. This is mainly a disease of men who have sex with men, but it does occur at a much lower frequency in women. And here we have congenital syphilis. Now, this is from a number of years ago now, and you can see that over the last few decades, that has definitely been declining, but it's not at zero. And here you can see the countries which have reported the most cases. Globally, syphilis remains a really, congenital syphilis or syphilis in pregnancy remains a really important infection. 1 million women were infected with syphilis in 2016. So it's something, and another global estimate was something like 0.7%. So nearly 1 in 100 pregnant women, over 600,000 infections in infants in 2016, and half of those led to adverse outcomes. And there's a very high rate of stillbirth and neonatal death worldwide from congenital. And if you compare that with the number of babies born annually with HIV, you can see that this is still a much more common problem. If you look how it's regionally distributed, you can see that most of these babies are in Africa and some in other regions as well. And you can see in the green the large proportion of stillbirths. So syphilis, if a mother is in syphilis for the first time in pregnancy, there's 100% transmission. Syphilis really likes the placenta and will cross over to the fetus. And up to 40% spontaneous abortion, stillbirth, or perinatal. This is a very nasty infection. It can transmit at any time during pregnancy or during delivery, and it increases the risk of premature delivery or growth retardation. So all women should have screening at booking. And if a woman has high risk, so if she's having multiple partners, or if she has other sexually transmitted infections, or if she acquires HIV, for example, she should definitely have a repeat screen. And always remember the woman who turns up unbooked in labor. It's not just important to test her for HIV or hepatitis, but also very important to check for syphilis. So the newborn, the classic stigmata of infection include hepatosplenomegaly, jaundice, pneumonitis, rhinitis, lymphadenopathy, and so on. However, the baby may not be particularly symptomatic and only be picked up later on. And the classic triad includes abnormal teeth, interstitial keratitis, and deafness. So sometimes this may not be picked up in the newborn, but only later on. And you want to do a careful assessment. A high-risk infant is going to be born to a mother who's either partially or untreated. And I mentioned already about the placenta, very important to do a lumbar puncture to see if the CNS is involved, and to repeat that lumbar puncture after treatment to make sure that it's resolved. X-ray the long bones. And really, if there are any evidence of syphilis infection through the blood tests or the clinical findings, then the baby should be treated. For a low-risk infant, so an infant born to a mother who has been treated, and where there are no stigmata of disease at birth, then the baby simply has to be followed up to make sure that it loses all the maternal antibodies. So worldwide, there has been from WHO a very important effort to eliminate mother-to-child transmission of HIV and syphilis together. So to bring these two infections together, to make sure that women get tested and to make sure that treatment is available. Some of you may be aware that over the last few years, there were actually shortages of benzathine penicillin, but that has now been resolved. So there are different countries, particularly in Africa, who have now adopted this rapid dual test, and that is really important. If you look in Justin's SCORCH article in the archives, you will see that we have a diagnostic algorithm there for the management of potential congenital syphilis, looking across the risk from low to high risk. Okay, so this is a term baby who was born in a hospital not very far from where I am now. It was a normal pregnancy, normal delivery. Mother has a food business. There were no pets. Mum had traveled in Europe only, but the baby had a very large and unexpectedly large head. No other abnormalities were found. The ophthalmology was normal. Hearing screen was normal, but as you can see, this baby's got massive ventricles and was actually sent to the neurosurgeons and Cmv shunt fitted at 5 days of age. Here's another baby, a 3-month-old infant who was not fixing and following, normal pregnancy. The parents had been for their summer holidays in rural France. The mum enjoys eating rare and cure meats. The father's a vet. They've got no cats. So these two children have the same in utero infection. And what is it? Yeah, you're right. This is congenital toxo. Now, toxoplasmosis, the end host for Toxoplasma, which is a microorganism of the same family as malaria, is the cat. And the cat secretes fecal oocytes and go into other small mammals, gets into the tissue of these small mammals, and then gets eaten by the cat. But occasionally, these get eaten by other animals who get eaten by us. Or they may be in the cat litter, or they may simply be in the soil and eat fruit and veg, which are not very well washed. And then that can get into the woman and into the fetus. So what's the commonest way of being infected with Toxoplasma? Well, it's not probably from cat litter. It's more likely to be from soil contamination or from eating rare meats or cured meats. Again, if you go to ECD, you can see that congenital toxoplasmosis is actually a rare condition with only about 1.5 cases per 100,000 in Europe. And you can see here the countries which are reporting and where it's more common. So it's an obligate intracellular protozoan, and congenital infection, transmission to the fetus, only occurs when there's a primary maternal infection in pregnancy. Interestingly, if the infection occurs in the first trimester, it's more difficult for the protozoa to go across the placenta, but if it does, the fetus is likely to be very severely affected. As the trimester progresses, transmission is much more likely to occur, and the fetus is much less likely to be significantly affected. This is data from the French cohort, which shows you from before and after 1992, when there was universal antepartum screening, at the diagnosis and probability of infection. And actually after 1992, they were picking up more third trimester infections. So an infant with congenital toxoplasmosis can be either asymptomatic at birth, but go on to develop problems such as retinitis, epilepsy, learning difficulties, or deafness, or can be very ill at birth, like the blueberry muffin baby. And like our baby who had the severe hydrocephalus. How do we diagnose it? Well, we can look for seroconversion in the mother. We can do amniotic testing in the fetus. We can make use of the placenta and look at the serology in the infant and do PCRs in the blood and the CSF. In the UK, we do not do screening for toxoplasmosis because it's really a very rare occurrence, but in other European countries, they do. And this was a study undertaken some years ago, looking at cases in different European countries where they did antenatal and postnatal screening. And this looked at the effect of treatment antenatally during pregnancy. And there was a suggestion that prenatal treatment reduced the risk of severe CNS disease. However, there are still difficulties with this because it's observational data, and there are no good complete randomized control trials of treatment antenatally, and guidelines across Europe are still very different. However, if a diagnosis is made, then you can offer spiromycin before 32 weeks gestation or pyrimethamine and sulfadiazine after. Postnatally, if we're detecting the infant, then if the baby is symptomatic, and definitely if they have ocular lesions or neurological problems, then we would treat. In the UK, if the baby's asymptomatic, we probably wouldn't treat, but we would say it's very important that the baby needs to have long-term follow-up for ophthalmology, because there is still a risk of lesions occurring in the eye at a later time. Again, if you go to Scorch article, you will see the algorithm for testing and treating. So I'm going to finish this talk off with a bit more about congenital CMV. And I often call CMV the Cinderella virus because many healthcare workers, including midwives and certainly the general public, have never heard of CMV. Although there are probably about 1,000 children or more born with CMV in the UK every year, and yet everybody knows about Down syndrome, everybody's heard about that infection you can get if you eat soft cheese, and everybody's heard about cats and toxoplasmosis, and yet those infections are much, much rarer. If you want to know more about CMV from a general perspective, you should go to the CMV Action website, which is absolutely brilliant and is set up by parents of children with congenital CMV. So in the UK, about 1 in 200 babies are born with CMV. And to make that diagnosis of CMV, congenital CMV, you must detect the virus in the saliva, urine, or blood before 21 days of age. Babies can be fairly rapidly infected with CMV perinatally and postnatally, and can acquire it from the birth canal and from the breast milk. And any mother, more or less any mother who is seropositive already for CMV will excrete the virus in her breast milk. So it's really important to get those samples before 3 weeks of age. And is it just small print? Well, absolutely not. And you can see here how much more common it is than all these other conditions which we screen for. And worldwide, if we say the overall newborn prevalence is about 0.5%, you can see that in some countries it's actually more than that. So which women are most at risk of congenital CMV? The ones who are most at risk are those who are frequently exposed to young children, because young children, infants and toddlers are getting infected with CMV. It's usually completely asymptomatic for them, but they will excrete the virus for some time in their saliva and their urine. And that is how they infect and indeed reinfect their mothers and carers. So as you know, CMV is a member of the herpes virus family. It's closely related to the glandular fever EBV virus. And with all the herpes viruses, when we get infected, when we have our first infection, we never get rid of the virus. We usually keep it latent and asleep in one particular cell line or another in the body. If a mother has primary CMV in pregnancy, and that's maybe something like about 1 to 3% of seronegative women, then she has a 30 to 40% chance of transmitting the virus to the fetus. So not every baby gets infected in primary infection. On the other hand, and this is the case for most women around the world, already seropositive, unfortunately, that does not completely protect your fetus from a reinfection. And in that circumstance, about 1 to 3% of babies will be infected. And mostly this is mothers coming across a new strain of the virus, usually from exposure to small children. Now, does it matter as far as the fetus is concerned, whether the mother is having a primary or a non-primary infection? And this is data from a very large French study carried out by our colleagues, Marianne Lheureuxville, in the Necker Hospital, where they looked at nearly 12,000 deliveries. And they looked at saliva from all of these babies to see if they had congenital CMV, but they also had the serology on the mother, and they had an overall prevalence of 0.37%. And out of these 44 infants, half of them had primary infection, and half of them the mother had non-primary infection. But when you looked at the effects in the babies, they were much the same. So the mother having some previous immunity did not protect the babies from getting severe infection. So there's a classic sort of paradigm of what CMV does to the fetus in the womb. And it's something like around 10 to 15% are symptomatic newborns, and they will go on very likely to have long-term sequelae. On the other hand, the majority are so-called asymptomatic newborns, most of whom are said to go on to be normal, but some will develop sequelae, which is mainly sensory neural hearing loss. Now, I'm hoping to show you that this is really a bit of an oversimplification. So the very symptomatic newborn, and here's an example, these babies are often born prematurely, they are very often growth restricted, and they may have involvement of multiple systems. So they may have retinitis, thrombocytopenia, brain effects, which I'll talk to you a little bit more, hepatitis, the gut and the lungs may also be affected, and the hearing too. So how do we make that diagnosis? And one of the things which is really tricky is if a mother has primary infection, then you can definitely demonstrate seroconversion. So she will have no antibodies at the beginning, and she will then have antibodies after the infection. Unfortunately, though, for a mother who has a reinfection, who's already seropositive, and actually worldwide, statistically, the majority of babies are born to mothers having reinfections, the serology is not at all helpful. For the fetus, we're able to, if we do an amniocentesis, we can get amniotic fluid, and we can do PCRs, and we can also do the scans. For the infant, again, remember the placenta, we want to actually get saliva, urine, blood, CSF, anything we can to look by PCR. Serology may not be helpful. And one of the things is if we don't do the tests before 3 weeks of age, we then may have to go backwards to try and dig out the Guthrie card, the dried blood spot, and see if we can look for the virus in the dried blood spot. The problem about this is that it has relatively low sensitivity, 85% at best. So a negative Guthrie card does not exclude congenital CMV. So the ideal samples to start off with are saliva and urine. They are our screening samples for congenital CMV, and they will always be positive. If you have a positive saliva, you want to confirm it with a positive urine, and the other way around. The blood tells us if the baby is currently viremic, but it's important to know that not all babies are viremic. You can still have a deaf baby with congenital CMV and abnormal scans who is not viremic. So the blood does not help you to define the diagnosis. And I already mentioned about doing the Guthrie in retrospect. So initial screening, urine and on saliva, then PCR of the blood. Look antenatally, all women will have a 20-week scan. And at the 20-week scan, if there's echogenic bowel or intracranial calcification, you might be very worried about congenital CMV. But the echogenic bowel has a differential diagnosis of other conditions as well. And if the mother is going on to have an amniocentesis, it's really important that a CMV PCR is done on that sample because even for a seropositive mother, this could still be congenital CMV. And you also need to make sure that you're taking that sample at least 6 weeks after you think the infection may have occurred, because if you take it too soon, you can get a false negative. So what happens if there's maternal viremia? It crosses the placenta, causes inflammation in the placenta, which actually can lead to fetal hypoxia and promotes the problem with growth. Once it's in the fetus, it will go into all the different organs. From the kidneys, it will get into the amniotic fluid in the gut. That's how we see the echogenic bowel, hepatosplenomegaly, ascites, cholestasis, and so on. And the brain effects may only show after the other organ infection and inflammation has resolved. This is from an Italian cohort of fetal autopsies, which shows you that they looked at all these different tissues, and the greater the amount of viremia, the greater the level of damage. And these were taken at around 20 to 21 weeks. So this is early first and early second trimester infection. But you know, brain involvement was only in about 2/3. So when you look at the MRI of the newborn infant, the kind of findings that you find there will help you to discern when the infection actually occurred. And early infection is related to what we call neuronal migration disorders. Is also more likely to cause calcification and cysts and tissue loss, so there's more likely to be severe microcephaly. How does CMV cause irreversible damage? Well, the virus gets across the blood-brain barrier into the blood vessels, or it can also enter the system via the CSF. So you end up with meningitis and ventriculitis, you get vasculitis, and early infection is what causes the problems with neuronal cell loss and absence of neuronal migration, and that leads to polymicrogyria and microcephaly. So this scan, these pictures from this baby's MRI scan, which you can see is very abnormal, comes from a baby where the mother had echogenic bowel at 20 weeks. And they did the mother's serology and it was IgG positive. So she was told, well, this baby definitely could not have CMV. But the baby was delivered at 30 weeks, severely growth retarded, microcephalic, with unilateral sensory neural hearing loss, thrombocytopenia, and conjugated hyperbilirubinemia. So this is a really important message. Just because a mother is seropositive already does not mean that the baby cannot be severely affected by CMV. And had she had an amniocentesis and had a CMV PCR on that amniocentesis, this mum might well have terminated her pregnancy. Sensory neural hearing loss with CMV is the leading cause of non-genetic hearing loss in children, and it's up to 1/3 of sensory neural hearing loss. Overall, it happens in about 10 to 15%. It's more in the symptomatic and less in the asymptomatic. But any child who's got unilateral or bilateral loss, it may well be quite significantly progressive. So you really need to follow these children up for the first 5 to 6 years of life. And all babies are going to be deaf on the neonatal hearing screening. So in some countries, such as Canada, they have now started saliva swabs in all newborns to pick up congenital CMV. So this is a study which really changed my view of congenital CMV, which was done by our Dutch colleagues, where they went back to all the babies who were born in 2008, and they got consent to dig out their dried blood spots. And remember, that's not 100% sensitive. And they found 156 children out of that cohort who were CMV positive on the dried blood spot, which gave an estimated neonatal prevalence of about 0.5%. So they knew they were in the right sort of ballpark. They then got permission from most of the positive babies to look at their healthcare records now that they were 5 to 6 years of age. And of note, of this group of 103 infants who were definitely CMV infected, only 3 had been diagnosed at birth, and only 1 of them was treated. But actually, 1/5 of them had symptoms. They matched them with twice the number of negative children for sex, birth month, and postal code. And then they looked at their national health records. Now, only 5 of these children had become deaf, and all of these were children with congenital infection. And this is a lower rate of deafness than has been seen in some other studies. But what is really crucial here is that moderate to severe long-term impairment was twice as common in the babies with congenital CMV as those without. And it occurred in half the children with any symptoms at birth, and 1/6 of those who were not symptomatic. And the commonest thing that these children had was particularly problems with speech and language, and also multiple domains being involved. And I think this really made me think that actually the problem is that in the past we said these children were asymptomatic, but we didn't follow them up long enough to know whether they were actually having difficulties at school and later on. So I think the spectrum of what congenital CMV can do to affect children in terms of their development is much wider than we used to think. So what do we need to do? How do we need to find out more about these so-called asymptomatic children? And all that really means is that they have no visible end organ disease at birth. But whether they have already problems, we don't necessarily know. So here is a so-called asymptomatic child, is a bit small, but normal examination, normal head size. And we only pick this child up because they have failed their newborn hearing screening test. But when we did an MRI on this baby, you can see the white matter abnormalities and you can see the cystic changes here. So the baby definitely has CNS effects. So if we're actually going to do something to reduce inflammation, reduce viral replication, and try and treat these children, who's going to benefit from that most of all? And if you think about the child who was infected perhaps in the first trimester and has got tissue and neuronal loss, is postnatal antiviral therapy going to make much difference to them? On the other hand, the later gestation and where there are white matter changes, is that actually, are we going to make more difference to that child's neurodevelopmental outcomes? And the problem is that the clinical trials we have to date have not quantified the degree or the timing of CNS damage. So we really don't know the answer to this yet. What sort of interventions do we actually have? Well, I think increasing people's knowledge. There are randomized controlled trials that if you teach women to wash their hands after feeding and changing children, you can actually reduce their risk of acquiring CMV. So that's one thing. In the future, we hope we might have CMV vaccination, but we haven't got it yet. A very severely affected infant in early pregnancy, well, a termination may be offered. And there are studies of using hyperimmune globulin, valacyclovir, not yet valganciclovir. None of these are completely supportive of these being effective. The study that what we do in terms of treatment for the newborn infant is around a 6-month course of oral valganciclovir, which has been shown moderately to improve the neurodevelopmental and the hearing outcome for infected infants. And obviously they need to be followed up. This is the study here where at 24 months, where babies were given 6 months of valganciclovir versus 6 weeks, there was a slightly better outcome for hearing and a slightly better outcome for development. So it's modest. We have the European consensus, and everyone agrees if there's CNS disease or other severe disease that you should definitely treat children. However, not everyone agrees to treat isolated sensory neural hearing loss with no other evidence, or to treat moderate disease with the CNS not involved. So we really, we don't have enough information on enough children to really know the answers yet. And valganciclovir is a drug that has short and potentially long-term side effects. And we, again, don't have enough data about the long-term follow-up of treated children. And in Europe now, we have set up CCMVNet, which is a registry to try and collect exactly that kind of data about the epidemiology, about long-term sequelae, about prognostic value of neonatal variables that we can better understand, and of course, possible long-term side effects. We've only set this up in 2020, and we already have a lot of interest from countries in Europe and indeed further afield. There are a lot of studies going on at the moment trying to ascertain whether you can treat children later. So if a child has hearing loss at a year or 2 years of life, could you actually treat the baby then? And would that help to stabilize the hearing and prevent further loss or even improve the hearing? And we're still waiting for these trials to report to us. So whilst we don't have cures, I think prevention is really the thing, and we need to be focusing on these public health measures and better education of the public, as well as hopefully in the future, vaccination and antiviral treatments in pregnancy. So congenital infections are rare events, and we need to make sure that we're working together with all the members of the MDT, the obstetricians, the midwives, the neonates, the infectious diseases team, so that we can make sure we optimize treatment before and after delivery. We need to think about what kind of infection screening are we doing in pregnancy, and might we be getting to a point where we should change the infections we're looking for or broaden the infections we're looking for. And it's absolutely the case that we need more research and better registries of congenital infection, which are international and help us to gather more information. So thanks for listening, and if you have any questions, I will try hard to answer them. And apologies for the fact that we couldn't get this onto presentation mode. Our Zoom knowledge is not that brilliant. So I'm stopping sharing and see how we go. And yeah, so I think we're still a group of 4. So Paul and Carly, I don't want to put you on the spot in any way. I hope you didn't fall asleep, but if you've got any questions, I'm happy to try and answer them.
I don't have any questions, but thank you. That was really good. Thanks for sharing that.
Pleasure. Oh, microphone isn't working. Do you recommend LP to screen CSF and asymptomatic baby? Okay, so that's an interesting question. In the UK, we don't generally do a CSF on an asymptomatic baby with congenital CMV. So we just base what we do on urine and saliva. In some countries, they do lumbar punctures on all the babies, but it hasn't really been shown to necessarily be that helpful. What I think is more important actually is to make sure that every baby has an MRI scan if they are found to be infected, because ultrasound is very good at showing you calcification. In fact, it's probably better than MRI, but it won't show you the white matter changes so well, and it doesn't really show you the migration abnormalities or the polymicrogyria so well as an MRI. So we try to do MRIs on all the babies, and actually it's easy to do an MRI on a newborn. You can just do a feed, you don't need any sedation or anything. So that's one of the things which I think is really important, because that helps us to get an idea. If we can see that there's inflammation there, then we're going to be more keen to treat. Now, interestingly, what happens 5 years later in terms of the baseline MRI, our Spanish colleagues have got some data on this, but it's certainly true that you can have a normal MRI at birth and have considerable learning difficulties at 5 years of age. And learning, communication, these children often end up being on the autistic sort of spectrum. These are all problems that you can pick up later on. Okay.
Hermione, I'm going to jump in and say a huge thanks, and I'll stop the recording. But this is really great, and please, anybody in the audience, let your friends know that there's a really, really good opportunity to learn about CMV, everything you need to know about congenital CMV. Let me see, I'll stop the recording here. Okay,